Good evening. My name is Michelle Kitson. I am an internal medicine physician practicing in Memphis, Tennessee. I am grateful to the organizers for the invitation to discuss the primary role for primary care in the relationship between internal medicine and oncology. I believe that the most important role I have is that of a patient champion. And in order for me to do so, I have to establish trust. That is, I've got to be open. I've got to be willing to listen. I was taught that we have one mouth and two ears because listening supersedes talking. And being relatable. I speak with my medical students, my interns and residents daily when I work with them about how important it is to find a point of connection with the patient so that they are able to relax enough, to be open enough for us to establish trust. Effective communication is paramount. If I am speaking what the patient interprets to be gobbledygook, then they're not likely to benefit from the interaction. And so it is important for the language that I use to be plain, to be easily understood. And I have to check in with my audience to ensure that they are actually receiving the information that I'm providing to them in the way that I'm hoping that they are. Effective communication in this arena and in any in medicine needs to be with the patient's family, and with colleagues also involved in the patient's care. As a patient champion, I have to have a level of patience that allows me to be persistent in determining barriers that exist that impact my patients. What do I mean? If we're talking about prevention strategies, preventing cancers, and we say diet and exercise are important details to focus on, then if my patient has no access to a supermarket, a grocery store that provides fruits and vegetables, then I'm setting myself up for failure, because if they cannot access healthy foods, I could speak till I'm blue in the face about eating well being a prevention strategy and not get the buy-in or the results that we're expecting. Another thing in minority communities is that there are not only food deserts, but there's oftentimes not transportation. In a lot of southern cities where there's not a rail service that is easily accessible, and there's not a regular bus line between areas that low income families live in and access to care, then them being able to go for their mammogram, to go for their colonoscopy, to go for their chest x-ray is all compromised. And so being aware of these things, making sure that I'm asking the questions where the patient reveals those barriers, is a way for me to ensure that I am championing for them. Being diagnosed, being treated, can my patients afford the medications? Do my patients understand what is being articulated to them, either by me, their primary care physician, or by the specialist that I've referred them to? A lot of times, patients will hear the big C word, and that's the last thing that they hear. And if they don't trust you, if you're the radiologist calling to give them the news that there was a mass, if you are the oncologist calling to speak to a new diagnosis that the patient was not anticipating or wanting to hear, being in a room with just the patient is inadequate, it's inappropriate. And so you often want support system, be it a family member or a friend, a trusted friend, there when these conversations are taking place. There are oftentimes health issues not directly related to the oncological care that the patient is receiving, but that have a huge impact on the success of the treatment. I often say that our patients are not diseases, they are human beings who have medical conditions and diseases. And because I know that I am definitely not versed at the many four-syllable um, words that often look like hieroglyphics to me and my patients for cancer treatments, I don't expect that my oncology and hematology colleagues are abreast of the latest and the greatest when it comes on to the management of diabetes, for example, the management of hypertension, of obesity, of overweight, making sure that I am aware of factors that could increase risk of heart attack or stroke. A big one that I feel is not often addressed in the oncological space, either because the patient is so overwhelmed and so they don't express to the physicians that this is a concern for them, or just that there hasn't been enough time to foster the kind of relationship where a patient feels comfortable discussing their mental health. That tends to be another huge factor that can impede the success of the relationship with the patient. And by mental health, I don't always refer to depression or having bipolar or schizophrenic diagnosis. It may just be the stress of work, the stress of family life. Oftentimes, cancer patients are parents, or particularly in minority communities, there are many of our patients who are taking care of their own nuclear family, so husbands, wives, and children, but they're also responsible for elder care in their family. If there's a spinster aunt or an uncle who may have special needs, who does not have someone else they can depend on, the strain of caregiver stress can be astronomical, and it can impede the patient's ability to respond well to treatment. Psychosocial support is another area that primary care champions. Being able to connect patients with resources that are available in the community is a big deal. It's not always brought up because, again, there is a lot of, due to incidents in the past, there's a lot of distrust between minority community members and the health profession. So there are a lot of times where cultural differences will exist. There's a great deal of pride that people feel they don't want to ask for help. And so they don't bring out the things that are truly fixable or amenable to the input of the team. But if there isn't a team and the team is unaware of these issues that are impacting the patient, so social determinants of health, if you don't have a permanent address, if you're bouncing from one area, one family member, or you're homeless, being able to follow up with a result, being able to follow up with scheduling a referral. These are all things that, if there's not a strong psychosocial support network, and if we're not aware as physicians of these challenges, then we again are doing our patients a disservice. Other things that matter are age appropriate vaccinations and health screens. Oftentimes, if somebody has skin cancer or a lung cancer, they may not be thinking that, oh, yeah, I still need to have my gynecologist perform a pelvic exam and a pap smear if it's appropriate. Yes, I need my colonoscopy to be done. I need my eye exams to be done. There are certain medications and disease processes that do affect other organs besides that which is primarily being treated with cancer care. And of course, again, with the age appropriate vaccinations in minority communities, there are lots of misconceptions fed very heavily during the COVID pandemic um, that have led to a lot of distrust. People are thinking that things are being implanted with vaccinations, that even if these allegations or thoughts have been debunked, people still think that there are vaccines that are directly related to the development of autism. And so we do have a lot of challenges with convincing patients to participate in things that we know are absolutely saving lives. I do think we need to do a better job of advertising. Our pharmaceutical partners are really big on getting time on the television, on social media, on all platforms, billboards, magazines. They are getting information out there that they want the patients to have. I think we've fallen off and we've fallen back as physicians in terms of being the voice of reason, of being the expert at explaining why vaccinations and other health screens are incredibly important, managing their high blood pressure and their diabetes as part of being able to augment and support oncological care. Big one for me, advanced care planning and goals of care. It has been my experience this last almost 11 years practicing in the state of Tennessee and in Memphis in particular, that a lot of people are uncomfortable with understanding that death and dying are actually natural processes. I am oftentimes motivated to, very early in my interaction with patients, start speaking of death and dying, not as something to be scared of, not as something to be, oh, I'm claiming disease because, oh my gosh, if I say the word death, if I say will, if I say a trust, then I must be implying that somebody is about to die imminently. I'll oftentimes flip it on myself and say, hey, we just don't know. We all come here after being born with a termination date, an expiry date. And what we have to focus on is living in the moment, but also doing our family a good service by thinking about and discussing what we would like in the event that a fantastic outcome is not what it's expected while receiving care. There is a definite art to balancing optimism and expectations. Lots of my patients have spiritual belief systems, religious backgrounds that may differ from mine in terms of how they process illness, how they think about death. And so, in those instances where the numbers are suggesting that some disease process is end stage as opposed to amenable to treatment, when disease processes recur, when there's metastasis, despite the treatments that have been attempted, these can be really crucial moments in helping the patient to deal and process and having that relationship with a primary care physician where over time trust has been built can help to make it easier um, for the oncologist when there has to be a change in direction of care, or even just for the patient's family and the patient. I'm big on code status. It is important to know whether or not the patient would want chest compressions to be performed on them. If a patient is riddled with disease impacting their bones, their quality of life is incredibly poor, do I want to encourage them to undergo the physical trauma that comes with CPR? Would they want to be on a ventilator in the event that we're unable to non-invasively bring their oxygen level up to supply their brains and keep them functioning? Connecting patients with entities that provide legal services, so getting them to have dual powers of attorney for medical and financial decision making, living wills, living trusts, and the like. Preemptive planning. What if cure is outside the realm of possibilities? What if we are not going to be able to cure the patient with chemotherapy or radiation therapy? What happens when faith and facts seem to be really far from each other? It is so important for us with preemptive planning to ensure that we rally the troops, have family engaged, chaplain services, group support, resources available at the American Cancer Society, palliative and hospice care teams. Key challenges I see is healthcare is a team sport. It's not an individual sport. The patient, physicians, and support personnel, family members, and the community need to all be involved. Primary care visit slots are at maximum 30 minutes for a new patient. It is really difficult in such a short space of time to establish the trust that's required to give the patients the support they need. We need our oncology and hematology colleagues to press that we get more time to help to care for their patients. There's a fear of the unknown, poor medical literacy that impede patient engagement. And we absolutely need to do a better job of reaching out to each other and ensuring that everyone on the team, primary care and hematology oncology, are speaking often enough to ensure that our patients are well cared for. I think it's time for us to change our model, and I look forward to all the support that I can get from my oncology colleagues and providing my input as often as it's needed. Thank you very much.